So, moving forward, hi, Dr. Ali-Osman. Thank you for taking the time today and educating us on such an important topic. Do you mind telling everyone a little bit about your background and how you got involved in plating in the rib fracture world?
Absolutely. First of all, can you hear me?
Yes, perfect.
Excellent. So thank you very much, Elia, for this opportunity, and thank you to Acute Innovations and for setting this up. It's my pleasure to talk today about a topic that's obviously very dear to my heart as far as rib fixation. When I did my medical school and general surgery residency at the University of Texas Health Science Center in San Antonio. And in my residency, we didn't fix ribs. I mean, like most residents are taught even today, don't fix ribs. It doesn't work. People have tried it, et cetera, et cetera, et cetera. And then I got to my fellowship where my program director actually was fixing ribs. And so initially I was very, very skeptical because it had just been drummed in my head that we don't do this until I saw how well some of the patients were doing. And so then it became very clear to me that I'm not saying that necessarily every patient with a broken rib needs to be fixed, but there are significant subsets of patients that can benefit greatly from this procedure. So my first job, which I'm still in my first job, I'm happy to say I've been here for about 6 years as part of Acute Care Surgical Specialists here in Phoenix, Arizona, where our practice actually runs 4 trauma centers in the greater Phoenix area. 3 of them are level 1s and 1 of them is level 3. And we've literally fixed ribs at all of them. And we have a pretty robust program and have done quite a few of these over the last 4 years. So part of what I want to do today is just kind of go through, our 4-year experience in creating a rib program. I mean, it was not easy, but we'll talk about some of the trials and tribulations and challenges that we face. And, I kind of put this presentation together, putting myself in the shoes of someone who's never done this before. What are the things that I've learned or that we have learned collectively, to get to where we are today as far as fixing ribs that I wish I would have known, when I first started. And so I think experience is the best teacher. And I'm happy to share that with everyone here today. All right, so we'll get started. So just a quick overview. We're going to talk a little bit about history, some of the literature, some of the details on starting a rib fracture program, patient selection, some of the different surgical approaches that we use and how that has changed since we started even doing the procedure 4 years ago. And then we'll take a look at some of the rib lock hardware and the BioBridge. Then go through a couple case presentations and talk a little bit about the Chest Wall Injury Society. So there's no doubt rib fractures have been around forever, since the beginning of man. The Edwin Smith Surgical Papyrus is actually the oldest known piece of medical literature. And even back then, they described fixing ribs. And back then, the recommendations are the same as what's considered a standard of care today, which is don't do anything, they'll heal. And when you think about it, to put it in the context of other aspects of medicine, I actually think it's a travesty that in all of these thousands of years, the accepted management for rib fractures is the same thing that we were doing 3,000 years ago, which is just, let them heal without doing anything for them. It's very clear that, we can do more, and there are actually tools out there to help us do that. Chest trauma, we know, is a persistent problem. 10 to 15% of all trauma admissions involve some degree of chest trauma. 25% of all traumatic deaths involve some degree of chest trauma. Now, not all those patients obviously died because of their chest injury. They may have had other things, TBIs, what have you. But chest trauma was identified in 25% of all traumatic deaths. Rib fractures alone occur in up to almost 40% of all blunt traumas and are associated with a significant amount of other injuries. And then rib fractures obviously can lead to pulmonary insufficiency and ventilator dependence. And historically, it's always been quoted that up to 60% of patients who suffer a flail chest cannot even return to their same level of work, even at 5 years post-injury. And this is the most widely quoted stat, which puts kind of flail chest in the front lines as far as the indications to perform rib fixation. However, we have to be very, very careful with the term flail chest. I personally think, and this is just my personal opinion, I think the term flail chest should be stricken from the medical literature because, what does it really mean? Historically, when flail chest was first described, it described, 3 or more ribs fractured in 2 spots that caused this paradoxical motion. When the patient would inspire, that part of the chest would actually sink in rather than come out like you would think. And it was an anatomical, physiological description. Nowadays, with all of our multi-slice CT scanners, et cetera, so many radiologists are now calling flail chest, even in situations where you might have like a bunch of tiny little cracks with no displacement of the ribs. But because there are 3 or more ribs broken in 2 spots, they're calling that a flail chest, essentially a radiographic flail. And that, still gets coded as a flail chest. And I would argue that patients with tiny little cracks that equal a radiographic flail chest, yeah, they might be in pain, but they may not be in nearly as much pain as somebody who has just 3 or 4 horribly displaced ribs that technically aren't a flail chest because they're in 2 different spots. So there's a lot of variability there. Not all flail chests are the same. Not all of them are equal. Same thing goes for, severe fractures that aren't flail. And so I think it's we have to be very, very careful, in selecting our patients and not do it just for flail chest. Not everyone with a quote unquote flail chest needs to be fixed. Not everyone that doesn't have a flail chest doesn't need to be fixed. And there's a lot of overlap. But I think the most important factors, and we'll get into this in a little bit more detail, is how is a patient doing clinically. I think that's more important than anything else that we talk about today. So, everything regarding the management of rib fractures revolves around pain, right? So, you break your ribs, it causes a lot of pain. That pain causes you not to, want to take deep breaths. You have impaired pulmonary function and mechanics, which can lead to atelectasis, which then increase your risk for pneumonia, ventilator dependence, and especially in this day and age, with the whole opioid crisis, a vast majority of these patients require some degree of opioid pain medication. So, just about anything that you could do with, one of your goals being to decrease the amount of pain medication that a patient needs to be on, for the most part, is going to be pretty well received. So for a lot of the naysayers, they'll tell you that, hey, there's no data to support rib plating. Well, that's actually not true, okay? And this was actually published in 2017 by Mark DeMoya in the Journal of Trauma, where they looked back at all the papers that have been published on rib plating. And actually, since this particular publication, there's at least 150 more. And yeah, not all of them are, your classic randomized controlled trials, but it's still good data, and it's still data, that directly addresses operative rib fixation. So for the people that say that, well, there's just no data to support it, I would argue with them that, all you have to do, you don't even need to get on PubMed. I mean, you can pick up your cell phone and Google operative rib fixation, you're going to find a bunch of papers. So I think it's important, if you're trying to start a rib plating program, that you make sure that you're well versed in, the most recent studies, and, you understand all the randomized controlled trials, which is really only about 4 of them right now, which we're going to talk about in a little bit, and look at all the advancements that have been made, especially within the last 10 years. So as we look at the prospective trials, okay, 3 big ones that I picked here. Number 1 is the Tanaka study from 2002. Now, this one is the most widely, quoted study. It was kind of like that first landmark paper that even put, rib fixation into the limelight. And it was a well-done study because it was randomized and it was a controlled trial. And, the problem was, even though this was a good study, they did this study really only on 37 patients, and all those patients had a flail chest, and all those patients were on the ventilator for at least 5 days. So they basically took a patient who came in, had a bad chest injury, had a flail chest, got intubated, And then after 5 days, they're like, man, we can't get these people off the vent. So why don't we randomize these patients and, take some of them and fix their ribs, and then some of them and don't fix their ribs and do what we, accepted as a standard of care and see how they do. And it was a very well done study, and they were able to show that, they decreased the ventilatory requirements. So the number of vent days went down, the ICU length of stay went down, the cost of care went down, and they showed an improvement in their pulmonary function tests. But again, these were flail chest only patients who were stuck on the ventilator and couldn't get off after 5 days. Another important aspect of this particular study is that they used Judet struts, which pretty much no one uses anymore for rib fixation. So this was before we had all of the myriad of hardware that's available to us today. But they did show that stabilizing ribs in this specific patient population clearly showed a benefit. And so this is really what is used by some of the surgical societies and some of the insurance companies to justify reimbursement. Sometimes they will say that they will only reimburse if it's done for flail chest and if the patient has failed, weaning from the ventilator. Marasco and colleagues from Australia in 2013 kind of recreated a very similar kind of study where they randomized patients, and they were able to show that they decreased vent days and ICU length of stay in patients again with flail chest. And this was published in the Journal of American College of Surgeons in 2013. And again, these were only flail chest only patients. Fred Piracci in Denver at Denver Health did a very nice study here. This was non-randomized, but what they did was they actually started fixing ribs on X date. And what they did was they went back in time about a year or so before they started fixing ribs, and then matched all those patients for the ones that they fixed the ribs in, and did a comparison analysis. And so essentially this was a prospective trial, but it was non-randomized, and they matched the subjects to historical controls. And what they found was they were able to decrease ventilator days, decrease the need for tracheostomy, and improve their incentive spirometry. And this was published in the Journal of Trauma in 2016. And in this particular study, it was not flail chest only. They call them severe rib fractures. So there's a whole set of criteria that they use to determine this. They talk about the displacements. They talk about their vent or support requirements, and that's how they determined whether they were severe enough or not, and the number of fractures as well. But the most important point here is that this particular study included patients, some of them that did have flail, but some of them who also had non-flail injuries but were very, very severe. And they also showed a significant improvement in their outcomes. We were part of this consensus statement in the surgical stabilization of rib fractures, and we created literally at the first Chest Wall Injury Society meeting, which I was honored to be a part of. We kind of got together and wrote some guidelines based on the currently available literature. And what we found is so many aspects of rib fixation, there just was not a lot of literature specific for rib fixation, but we included everything that we had until that point, and I think it's a good read for anyone who's thinking about starting a program, so you can just have a little bit better understanding on various aspects. I mean, we talked about everything from patient selection criteria to how to deal with chest wall defects to pre and post-operative management and algorithms, etc. And it's a pretty easy read, and I think it's a good thing for anyone who's thinking about starting a program to read and understand. The next big study was a multi-center study. To date, this is the largest series of rib fixation, of which we actually contributed. I think we contributed the most patients to, and there's like almost 600 patients in this study where we looked at the timing of surgical stabilization of ribs. And we're actually going to go over that study in detail here in just a minute, so I'm not going to say all of that now. And then the next study, the next paper is from the Eastern Association for the Surgery of Trauma, where they created this practice management guidelines based on the available data. Again, in these EAST guidelines, they recommend rib fixation for flail chest. They say that it can be considered, for other scenarios. However, this is considered quote unquote experimental. And then the last one here is a study that we published in the the American Journal of Surgery, which we looked at. We have a geriatric trauma program here in Phoenix, Arizona, where we looked at all of our geriatric patients, and we're going to look at this study in a little bit of detail as well. So this is actually that study. So we'll start off with that one. And so what we did was we looked at, we do pulmonary function tests where we look at their forced vital capacity and forced expiratory volume in 1 second, in 1 minute, in 1 second, over pre-op and then at post-operative day 2 and post-operative day 5. And what we found was that we had a statistically significant improvement in pulmonary function by postoperative day 5. At postoperative day 2, we had a trend towards improvement, but it did not reach significance until postoperative day 5. So really, actually, based on this data, we actually adjusted our protocol a little bit to where we don't even check pulmonary function tests at postoperative day 2. And then what we did was similar to what Fred Piracci did in his paper. Was we matched these patients to historical controls in the last year and a half before we started fixing ribs and looked at various outcomes. And so what we found was the hospital length of stays in these geriatric patients. We saw a difference in the patients that we fixed. The patients that we fixed tended to stay in the hospital a little bit longer. So at first glance, you can look at that and say, well, if you fix the ribs in an older patient, you're going to keep them in the hospital a little bit longer. And that is true. I mean, these patients have a chest tube. But remember, most of these patients are leaving the hospital and not going home. They're either going to skilled nursing facilities, long-term acute care centers, or rehab centers. So as we looked a little bit more at the discharge disposition, we had a much more favorable discharge disposition in the patients who we fixed. A higher percentage of them were able to go home. A higher percentage of them were able to go to acute rehab instead of a skilled nursing facility. So there was a much better discharge disposition prognosis when you fix the ribs in these patients. We also looked at deaths, and there were significantly more deaths in the patients that were managed non-operatively. But we have to be very careful, in looking at that, because there's going to be some patients who had, multiple injuries that they would have died anyway from, and those patients would not have undergone rib fixation, because of the other injuries, and the severity of things that were going on. So, we're actually in the process of looking at that group a little bit more closely, because I think it's a little premature to make the claim that, hey, you fix their ribs and you save this many more lives. I definitely do think that there's some degree of a survival benefit, but I don't think it's as great as this data may suggest. The next study is the multi-center study that we talked about just a few minutes ago, and this is one that we were a part of as well, and it was done between 4 trauma centers with Fred Piracci and his group in Denver, with ourselves here in Phoenix, Arizona, with Tom White and his group in Utah, in Salt Lake City, and with Andy Dobin and his group over at Bay State Medical Center. And what we found was we were looking specifically here at the timing of surgery. So when do you do the operation? There's no question when we started fixing ribs, we kind of waited to kind of see which patients, we think were not on a good trajectory. Sometimes they'd have some associated injuries that you needed to make sure were stable before you actually proceed. And what we found is that as the study, pushed on, we became more aggressive, and we're getting patients to the operating room earlier, later on in our experience. And so we looked at over 8,000 patients that had rib fractures at these 4 institutions. We looked at there were 731 of them which we identified as had at least one indication for rib fixation, and of those, 550 of them, or 551 of them, underwent operative fixation. And we had it separated into two groups, the early, a middle, and the late. And a majority of the patients were in the early group. What we found is our group, because the other centers that were involved in this study had been fixing ribs longer than we had. Now, we've done more than them in a short period of time, but, some of them had been fixing ribs for as much as, 5 or 6 years prior to us. And so we were actually, we had a higher percentage of patients in the late group, especially early on in our experience. And this actually also has pushed us to be more aggressive with our protocol, kind of be on par with some of the other high volume centers. And so when we look at the data, we look from 2006 to about 2016. And what you can see in this graph is that the number of patients that were plated in the late group, you look here from 2006 to 2011, over 60% of them were in the late group. And as we get to 2016, we're down to 20%. And as you can imagine, there's an inverse rise in the early and the mid groups. And now over half of these patients are actually being fixed in the early group. And so that's just a trend in, from 4 different high volume rib centers. And so when we looked at some of the variables in this study, what we found was that the length of the operation was longer if you operated later. And if you're anyone who's done enough of these, you can kind of understand why. Because even if you wait for more than about 48 to 72 hours, there is a lot of inflammation that builds up. There's a lot of this inflammatory tissue that you kind of have to dissect away. The anatomy is not quite as easy to discern. Sometimes if it's a rib that was like really displaced, it's not quite as mobile because of this. And so these operations tended to be a little bit more challenging if you waited more than 48 hours. And, that was clearly shown here with the length of the operative time. And then what we found is the later you operated, the longer those patients generally stayed in the hospital and in the ICU. And also the patients who you operated on later also required mechanical ventilation for a longer period of time. But when you think about it, that all inherently makes sense, right? So, I think based on this, the paradigm needs to shift from the things that they talked about in the Tanaka study where they basically looked at it where, okay, let's try to identify the patients that aren't doing well and then fix them, to where maybe we can fix people earlier and not even have to have them go through that. Because as we all know, as providers, once patients kind of start on that downward spiral, it becomes harder to stop that, So if you can identify patients you think are going to benefit and fix them early, well, maybe they don't have to end up on the ventilator. Maybe they don't have to get a pneumonia and sit there struggling for 3, 4, 5, 6 days, before you finally decide to fix their ribs. Maybe fixing them, within the first 24, 48 hours will put them on a trajectory where by that time they're able to get out of bed, do better on their IS, and decrease their risk for all of these bad sequelae that are associated with the rib fractures. So the conclusions of this particular study, we showed that early fixation is preferable whenever possible. You can decrease the ventilator days, decrease the ICU length of stay, decrease the hospital length of stay, and decrease your operative times. So really the meat of this presentation is starting a rib fixation program. And I can tell you that, if you're at a place where they haven't really fixed ribs much, this is going to be a tall order, and we know firsthand because, we lived through it and had to go through all the ups and downs. And so what I'm going to do is share some of our experiences with you and, some of the challenges we had to face, which are very similar to a lot of things that other folks may have to face at their respective institutions. So first and foremost, if you want to fix ribs, you pretty much have to be at a trauma center. You're just not going to get the volumes that you need to get if you're not at a trauma center, because most of the patients that break their ribs, it's from trauma, and normally it's pretty significant trauma. So they were in an MVC, going 60 miles an hour. They got thrown from their motorcycle. They, you have an old lady with osteoporosis who fell in the bathroom and broke 10 fractures. Most of those patients are taken to trauma centers. So if you're not at a trauma center, the amount of patients that you will even get a chance to evaluate for rib fixation is going to be significantly diminished. You always have to remember this is a multidisciplinary approach. So depending on where you are, there are some places where, the thoracic surgeons are the ones who will decide if they're going to be fixed. There's some places where orthopedic surgeons are fixing it. Believe it or not, there's some places where plastic surgeons are fixing them. But by and large, a majority of rib fracture fixation throughout the country is done by trauma surgeons. And trauma surgeons are really the gatekeepers, right? These patients come into a trauma center, they get admitted to the trauma service. If the trauma team does not consult the thoracic surgeon or the plastic surgeon or the orthopedic surgeon or whoever fixes ribs, that specialist is never even going to hear about these patients. Also, the trauma team and especially the trauma director have to be on board with rib plating, which isn't always the case either. And so if your team doesn't believe in rib plating, or believe in the potential benefits of rib plating, it's going to be very, very difficult. And so you've got to kind of change that thinking by, quoting some of the literature that I just quoted, showing some of the most recent studies and the results, and try to help sway people's minds in that way. And then I always recommend starting with the more straightforward cases. There's tons of cases that we do now, today, that we would not have done when we first started, because anytime you're new somewhere, the very first thing you want to do is make sure you have as good an outcome as possible. So you don't want to do the 500-pound guy with COPD, and uncontrolled diabetes as your first case. You do that, the risk for complication, no matter what you do, is going to be high, and sometimes people can use that as a reason, not to be supportive of your endeavors. And so again, trauma center is the key. Okay, trauma patients. Remember, a lot of these patients are polytrauma patients, so they may have a head injury, a cervical spine injury, a femur fracture, an open book pelvis. I just fixed a lady yesterday who, came in initially in hemorrhagic shock with an open book pelvis, who got a pelvic X-fix. We made sure she was stable, and the very next day, I took her to the operating room and put 7 plates on her ribs. She's doing much better now, and she's actually in the operating room today getting her formal ORIF of the pelvis. And so this is a perfect example of this type of patient. Even though you could look at those ribs when she first came in and say, hey, I should probably fix these, obviously her pelvic trauma, had to be controlled first. And then it's important to coordinate the care because, you have these polytrauma patients. Maybe the plastic surgeon needs to fix their face and the spine surgeon needs to fix their back, and they're doing it all in one day. Then you can see if, maybe you can tag on once the back is stabilized, just turn her over on her side and fix the ribs during the same operation as long as they're stable. But it's important to coordinate all these, these operations with the other specialists that may be involved in the patient's care. And then I can't emphasize enough, I know I mentioned it, just a few minutes ago, but the trauma team, especially the trauma director, has to be on board. I've talked to a number of surgeons at centers where the trauma director does not believe in rib plating, and sometimes these surgeons feel sabotaged because, I've even heard, extreme examples of certain members of the team hiding patients from them because they didn't want them to fix their ribs because they don't believe in it. And so you have to get your whole team on board, at least to the idea of doing some of these, and evaluating their results. So it's also very, very important to have a protocol. Now, I'm sharing with you kind of our original protocol for rib fracture management. I know this is a very busy slide. You're not going to be able to read every tiny little detail, but I did highlight and put in large here the part of it that we included the rib fixation. And so basically for our initial pain control, we put them on scheduled pain medicines. I actually have not written for a PCA in about 3 or 4 years. And in my residency, everyone with multiple rib fractures got a PCA off the bat, to try to get ahead of their pain. We do scheduled IV Tylenol, although very recently that has been taken out of our hands. There was a hospital-wide initiative, and so now we do scheduled PO Tylenol. We give them 1,000 milligrams every 6 hours, and we schedule it. We also schedule NSAIDs if they don't have a contraindication. The problem is probably more than half the trauma patients, when they come in through the door, have some contraindication for NSAID. Maybe they have a small subarachnoid, or there's a pelvic fracture with a little hematoma, or there's a hemothorax. And so sometimes we're not able to add the NSAIDs on for a couple of days. But if you can do it at the very beginning, there's no question that NSAIDs are one of the superior pain medications, for rib fractures. And then we have a very robust anesthesia team who will evaluate patients for thoracic epidurals for us very quickly. And so about 35% of the patients that we have in our program that get their ribs fixed get a thoracic epidural as well, which is actually very high compared to a lot of other places. We always get a respiratory therapy consult. We have a volume expansion protocol, which includes scheduled nebulizers and easy PAP therapy every 4 hours. And the respiratory therapists do our bedside pulmonary function tests for us. PT and OT are involved immediately. These are all pretty routine things for any trauma patient. And then we get a nutrition consult, and we get our bedside PFTs, and we consider early plating if applicable. And we left it very vague like that because the clear-cut criteria still have not been well defined. And so, it's more of a, we look at a number of different factors, which we'll talk about here shortly, and try to identify the patients that we feel will benefit the most. It's important to note, their IS, how high they can get on their IS. One of the biggest things I always tell our residents and our students here is that you have to ask the patient to cough, because they'll tell you that the patient was fine. They weren't on any oxygen and they were lying in bed, but that's because they're not moving and they're taking 200 cc's of breath, and of course they feel okay then. But if you ask them to cough and they can't do it, or they do it with immense pain, that's a indicator that that they may benefit. And then we look at how patients do each day. And actually, we've become a little bit more aggressive in that if someone's in immense pain, even in the first day, even if we start them on all the meds, within 24 hours, we're normally fixing them. And so some of the medications that we give, we talked a little bit about the Tylenol. We schedule the Tramadol, and then we put them on some low-dose oxycodone. This is all in opiate-naive patients, of course. And then Toradol, if they're not an epidural candidate and they don't have any other contraindications, is a great adjunct. And then for severe pain, we'll give them a little bit of fentanyl. All the patients also get a lidoderm patch. There's mixed reviews on the efficacy of a lidoderm patch. However, it doesn't really hurt the patient, and so there's some patients that will tell you that they feel like it helped them. Some of them will say they feel like it helped them a lot, and then someone will say that it didn't do anything. But it doesn't really hurt them, so we add that to our protocol. And, of course, the nebulizers and the easy PAP every 4 hours. And so our goal in these patients is if I can have an opioid-naive patient and get them out of the hospital in, on some PRN oxy with some scheduled Ultram and some scheduled Tylenol for, for about a week or two, you've done better, way better than, we have historically. Because historically, a lot of these patients end up on on high-dose narcotics, some of them even long-acting narcotics with short-acting for breakthrough, and these are in opiate-naive patients. And especially when you're talking about older patients, now you have a 90-year-old who's on MS-Contin and taking, a bunch of oxycodone because they broke their ribs, and yeah, they were breathing better, but now they're dealing with all the sequela of the opioids and unable to get out of the nursing home, et cetera, et cetera, et cetera. So our goal is, if we can get you out of here with Tylenol, Tramadol, plus or minus NSAID if you can take it, and then just a little bit of PRN Oxy 5s, that's a huge win. As part of our evaluation in our protocol, we do chest x-rays. Of course, everyone should do that up front just to make sure they don't have a big hemothorax or pneumothorax or something that needs a chest tube before you get better imaging. And then we always do our CTs of our chest with 3D reconstructions with and without the scapula. Now, it's very, very important to note that a chest x-ray is highly insufficient to evaluate a patient with severe chest trauma. I can't tell you the number of times that a chest x-ray has come back and said that there's no fractures, and then you get the 3D recons and your axial CAT scans, and there's 10 fractures. We see it all the time. And so, and you see this a lot with ER docs where someone will come in, maybe they didn't call the trauma team, the ER doc saw them, did an X-ray, and said, hey, you don't have any broken ribs, but I know you're hurting. Here's a little bit of ibuprofen, and then make sure you follow up with your PCP. And then that same patient shows up 3 or 4 days later with immense pain, and then you get a CAT scan, and you're like, oh, you've got 8 broken ribs. I've seen that happen time and time again. The other big thing is incentive spirometry. Make sure you get them one. You know how much they're able to do. And then the bedside pulmonary function test, we take a big interest in this because this is a very, very objective way of looking at their pulmonary mechanics. If you go with just pain scores, those are highly inaccurate, as we all know. I mean, there's people who are sitting there playing on their cell phone that'll tell you they're in 10 out of 10 pain. And then people who are, can barely talk to you who tell you they're 9 out of 10. So it's very important, I think, to have some sort of objective measure of how well they're doing from a pulmonary standpoint. Additional interventions to take into account, it's important. Talk with your anesthesia team. Ask them, hey, do you guys put in epidurals? Would you guys be willing to put epidurals in our thoracic epidurals in our, some of our rib fracture patients if we need them? And so it's important to have a good collaborative effort with them, not just for the epidural, but also for the operation itself. Okay, and then you need to consider operative fixation and figure out where you're going to include that in your management algorithm. And we now put in on-acute pain catheters on all rib fractures that we do, unless a patient has a contraindication to local anesthetic. And we started doing this after we'd done about 40 or 50 cases. There's no question that there's a lot of data that, supports use of paravertebral blocks in the management of chest wall pain associated with rib fractures. And one of the things we wondered is that, what if we just we're already in the operating room, we have the ribs exposed, what if we just put these pain catheters in at that time? You can lay it exactly where you want it to go under direct visualization, and maybe that will help their pain. Doesn't really hurt them. And so now we do that on all of our cases. There are some folks who will use other techniques such as cryoablation, to try to augment, the benefits of the operation as well. And then of course, we continue with our pulmonary toilet. We actually created this rib pillow, kind of like the heart pillow that the cardiac patients get. We got a rib pillow because one day we came in and one of our rib fracture patients had a heart pillow. And we looked at each other, we're like, we should make a rib pillow. I mean, we see enough rib fractures that, and so we actually, got this design and created a rib pillow. So all of our rib fracture patients get one of these pillows to help remind them to, to splint with it and use it to help their pulmonary toilet. So our post-op management protocol, we're out of bed no later than post-op day 1. You get PT and OT involved early. Early ambulation is paramount. We use our pillow for splinting, and we do bedside pulmonary function testing prior to discharge. So now we do it preoperatively, like actually when they first come in, and then we do it before they discharge, so we can track and have an objective number on how well their pulmonary mechanics are improving. And then again, in the opiate-naive patient, the goal is to discharge them with scheduled tramadol, acetaminophen, ibuprofen, and a lidoderm patch for 1 week, and a 7-day supply of oxy. If you can achieve that goal, you've done very, very well for these injuries. Patient selection. So this is, one of the difficult aspects of trying to decide who to operate on. So just certain factors are taken into account, and it's not that any one of these is important. It's that they're important collectively. And, a patient may have all of these, and a patient may have some of these. So number 1, are the rib fractures displaced? Well, you can tell that by looking at the CAT scan, but I will caution you, don't go by just the CAT scan. Remember, the CAT scan is a quick snapshot of what the patient's ribs look like at that time when they first came in, where they were log rolling them and making sure they don't move them around too much. I can't tell you the number of times that I've operated on a patient where the fractures on the CAT scan said they're not displaced, and then you go in there and there's like a centimeter of displacement. It happens more often than you would think. Flail chest. We already talked a little bit about the problems with that nomenclature. and what does it exactly mean. But if you have someone who has a classic paradoxical motion, which you hardly ever see, or has displaced rib fractures three or more on three or more ribs in two places, then that's a patient that is more likely to benefit from this operation. Remember, pain is really the main indicator to fix these or not, because it's the pain that causes all the problems. If they have pulmonary insufficiency, let's say they come in and they're in so much pain and can't breathe, and you have to intubate them right away. If they have respiratory failure, let's say they come in and within a couple hours, you have to intubate them. If they fail medical management, you should consider it. And I put symptomatic delayed non-union because we've done a few of these, but I think that's a whole different beast, and that's, I could talk for hours on that alone. And so that's really out of the scope of this particular presentation. And then, of course, the fractures have to be anatomically reachable. So we generally don't fix the first or second ribs. The third rib is kind of a plus or minus, and we generally don't fix, definitely 11 and 12. Every now and then we'll fix 10. If you have to address the 11th or 12th ribs, the times that I have addressed them, I've actually just resected that portion. And these were in scenarios where patient had significant chest trauma and got a spleen injury from the rib poking into the spleen. Well, I took them out, and let's say the spleen, we were able to preserve it, but we want to make sure that, obviously that part of the chest wall doesn't poke the spleen again when the patient rolls over. So I have gone in and resected the distal end of the fracture on the 11th and 12th. If it's a 10th rib, I have put a plate on that before too, but mainly for that reason, not so much for pulmonary insufficiency. All patients get a preoperative CT scan with 3D reconstruction. The positioning is important, supine, prone, lateral, wherever the fractures are. So if you have anterior fractures or anterolateral fractures, sometimes they're better off supine with a bump. If you have very lateral fractures, sometimes they're better off on their side. If you have a flail segment and you've got two fracture lines you need to address, sometimes they're better off in the lateral position and you make two incisions rather than one huge incision to try to get to all of them. We use double lung ventilation on all of these cases. We have not once to date in all the fractures that we've done had to use single lung ventilation. Bronchoscopy if necessary, if it's a patient who's been there for a couple of days or you think they may have aspirated, quite often I'll put a bronch. We use these disposable bronchs here, and we'll make sure that their lungs are nice and cleaned out before we put them on their side. Because remember, once you position the patient, especially if you're putting them in the lateral position, now you're taking all the secretions from the bad side, and they're all going down based on gravity to the good side of the good lung. And so, ideally, if they have a lot of secretions, you want to make sure that they're as cleaned out as well as they can before you make the incision. And then, of course, you have to choose your incision based on where the fractures are. There are minimally invasive techniques that we institute on probably about 95% of the fractures that we fix. And then subscapular fractures can be challenging because, they can be tucked way up under the scapula, but there are methods to kind of get under the scapula and lift it up with a retractor, and using 90-degree instruments, you can actually get a lot higher up under the scapula than we initially thought. We always wash out the chest with at least 2 to 3 liters of warm sterile saline. We just pour it in there, make a little hole in the intercostal muscle, pour it in there, and then put a pool tip sucker in and keep sucking until everything comes out clear. Our chest tubes now, we use 24 French fluted Blake drains. They're much less painful. You can put them right in the OR, easy to do, and you just hook that end up to a pleurovac as usual. And then always consider your adjuncts, the ON-Qs and the thoracic epidurals, plus or minus cryoablation if that's something that you do. So 3D reconstructions, obviously the biggest advantage of these is, it helps as a roadmap for the surgery, but I think the biggest advantage is it helps in counseling the patients and their families, because patients can't really relate that well to the typical axial CTs that we get. And so the 3D recons, a third grader can see that and say, wow, those are my ribs. Wow, they're broken. Wow, it looks like they're separated. And so the patient can really, really relate to these pictures. And I think that's where they're of the most value. As far as our incisions go, when we started, and when I first started to learn how to do the procedure, we made the standard large, either anterolateral or posterolateral thoracotomy incision. What we found is we've been able to spare much more muscle and get down to the fracture and have good results just by going where the fractures take us. One of the things to take into consideration when you position the patient is that sometimes, because if they're on their side and the arm is up, the location of the fractures in relation to the tip of the scapula can change because the scapula moves some. And so one of the things that I do is once a patient is asleep, I'll take my big fat hand and push on their chest. And if I feel a little pop, I know there's a fracture there. So I start off with a smaller incision there, and then once you get in and get down to the chest wall, you can actually feel around for where some of the others are and tailor your incision that way, and that way you keep your incision size to a minimal. When we look at some of the hardware, you have the traditional anterior plates, which is just about every other system, and then you have the rib lock system. One of the biggest advantages of rib lock is that the screws lock into the back of the plate, which makes it more secure. So, for example, if you have osteoporotic bone, it can be very, very helpful because we all know that, the osteoporotic bone can break very easily. They also don't hold screws very well. Also, with the U-plate, you protect the neurovascular bundle a little bit more than if you use a standard anterior plate that has bicortical fixation. And so, the rib lock system was literally developed only for this. And Acute Innovations, all they do is chest wall reconstruction. So they're very, very detailed. And as you use some of this equipment, you will find that the rib lock system, is very, very well engineered. I mean, you can just feel it in the tools as you use them. It's very, very precise. The way the clamps are set up, if used appropriately, it'll line up those screws perfectly straight through the thickest portion of the rib and lock into the back of the plate. And this is kind of just a quick representative picture of what the system looks like. You've got various plates of various sizes, lengths, and then you've got some of the drill guides and the clamps that secure the plate to the rib, and then you've got your bender, your forceps. You've got these here in situ benders. So there's a myriad of tools, and then all the random assortment of, not random, but the assortment of different screw lengths based on what the guide tells you. So you put the plate on, you hook it over the top of the rib. You do have to make a little bit of a hole in the intercostal muscle to get the clamps over, but that's very minimal. And then once you put these on and you secure them down, then it'll tell you what color. And everything is color coded, so it's very easy. So it'll tell you which screws to use, et cetera, et cetera, et cetera, to get the screw to just the right depth that's needed. This is a picture of the plate. It's a flexible titanium plate, and this is where the screws go, and then this is really the short plate, but they do have varying lengths. And what I found in using the system is once you get the two on the end, most of the time you don't have to put very many screws on the middle. Now, the times where that comes in the most handy is if you have multiple fractures and you have a segment of rib that's loose in the middle. If you want to put a screw or two in there to pull that segment up and keep it in line so it can heal appropriately, that's where it comes in most handy. But most of the time you have to put in either none or maybe just one or two screws in the middle just to help secure your plate. So here's a quick representative 3D CT. You can see here this patient had a flail chest. You've got a fracture line here and here, and this was the finished product, multiple plates. You can see that some of the fragments, they used a long plate to encompass both of them, and then some of them they used two separate plates. It just all depends on the type of fracture you have and what it's given you. So we'll take a look at a couple cases where we've actually used the rib lock system here in our practice. And the first case is a case of failure of anterior plates. And so this was a 61-year-old male. He was admitted in March of 2017 after a motorcycle crash. Now, of note, this patient had a history of a chronic tracheostomy secondary to tracheal stenosis, when he had hurt himself before and didn't have his ribs fixed at that time. Ended up on the ventilator, had to have a tracheostomy, developed tracheal stenosis. And so this is a very, he's an active 61-year-old. He rides his motorcycle every day, lives his life, but just has a trach because he has tracheal stenosis. So he's not vent dependent. So he came in after another motorcycle crash with badly broken ribs. So this is his initial 3D reconstruction. CT, you can see multiple displaced fractures. You can see here, actually, this is where his old fractures were, and you can see that they healed very, very crooked. So this is the natural history of, of badly broken ribs that are displaced that aren't fixed. They heal this way. And it's a big part of why, the pulmonary mechanics for the patients aren't always the same. But these are the acute ones, and these are the ones that we were going after on this particular hospitalization. So he came in and was put on the ventilator almost immediately, was in excruciating pain. And so this was his x-ray on post-op day 0. We used anterior plates here. You can see multiple plates here on the lateral side. We had a good fixation. He did have a pulmonary contusion too, so this is the haziness that you're seeing on the right lung. But his pain was markedly better, like almost immediately after the surgery, you could feel a difference. By post-op day 3, he all of a sudden was in immense pain again, and we're wondering what was going on. Well, we went back and looked at the x-ray from that morning, and it looks like some of the plates may have pulled out based on this x-ray. But remember, x-rays aren't that great for this. And then you see a loose screw here. And then we got a CAT scan, and then you can see exactly what's going on. So these were the anterior plates that we put in, and you can see that they've pulled out, and now he's completely separated again. And I did note in the operating room that it seemed like his bone quality was very poor. Like, the screws went in, but they just did not feel as secure as they normally do. So, it later was revealed that he did have some osteopenia. And so you can't really do the same thing and expect different results. So at this point, I said, we need to use the rib lock plates for this because clearly just the anterior plates, didn't work, and I'm not willing to put this patient through an operation again and try and do the same thing with the same system. So we went ahead and used the rib lock system, and this was the post-op CT here. And you can see that, everything is well lined up, and the patient did really well, and his pain relief got better overnight again, and the rib lock plates obviously did not pull out because they were all secured nicely in the back of the plate. The second interesting case that I have here is the use of BioBridge. Now, Acute Innovations makes a product called BioBridge. Some of you may be familiar with it, but I do remember from giving a number of lectures, one of the most common questions I'm asked is, do they make absorbable rib plates? And I always answered no, until one time I stumbled, I was hanging out in Portland, Oregon, minding my own business, and decided to go visit the Acute Innovations folks, and I see in their office that I see this BioBridge, and I asked, well, what is that? And that's our absorbable chest wall reconstruction plate. I was like, well, what is this used for? Well, the most wide usage of it is in thoracic surgery, where they have to do these big tumor resections where they resect large segments of the chest wall, and now you have a big gaping hole in the chest wall. Well, it's used quite frequently in that. It's also used in sometimes in pectus repairs. Dr. Miller, who is really probably the world's expert in use of BioBridge for chest wall reconstruction, actually was gracious enough to lend an hour of his time before I did this case, and he really, shared so much of his expertise with me that I really appreciated, because it really helped deal with this big challenge. And so basically this was a 28-year-old male who suffered a gunshot wound to the kind of upper abdomen chest. It was actually a shotgun. He was playing with the shotgun. It went off. It blew through his upper abdomen, tore up his diaphragm, tore up his transverse colon, nicked his spleen, and then he had a whole bunch of buckshot in his left chest, and his entire costochondral junction was blown away. So he went for a laparotomy the first day, and you can see his laparotomy incision here. This was one of the blast injuries, and then this was where his chest suit was. And you can kind of see this indentation of his left anterolateral chest wall. So there's all this buckshot in his subcutaneous tissues. How he didn't hit his heart and die, I can't really explain, but somehow he didn't. But he had a big hole in his left anterior chest right at the costochondral junction. So essentially the costochondral junction was completely blown away. Now I'm going to shift from here to show you some videos of that particular case. Just minimize that for a minute. And so this is us kind of cutting through. Okay, we're going through the skin and subcutaneous tissues. There was a lot of damage to the soft tissue a little bit underneath the skin. And then there's this big gaping hole that you can literally reach in and you're touching his pericardium and his lung. And so that's what we encountered when we first got in. We had to be very, very careful not to be too aggressive, to injure anything below. But once we got everything exposed, we were able to see what we were dealing with. And so what we did was we used a piece of biologic mesh and put that in an underlay. And but we first had to identify the extent of the injury. So here you can see that the suture is around the rib portion. The tips of my fingers there are reaching under the sternum. You're looking directly at the pericardium and the lung. All that tissue is gone, and this is all from the trauma. And so there's a big gaping hole, and you can see that the chest wall is mobile. And this is a very challenging scenario to have to deal with. And so thanks to Dr. Miller's expertise, it actually made the operation not that difficult because he told me exactly what to do. And guess what? He was right, because the man knows what he's doing. And so what we did was we put in our mesh. Now, Dr. Miller uses an overlay bovine pericardium mesh, which we don't have. I use a piece of Stratus biologic mesh and put it in an underlay fashion. Then took my my BioBridge plates and put a bunch of them together and laid it on over the defect, and then everything was nice and fixed and stable. Now these BioBridge plates absorb in about a year. They're made of polylactic acid, and the whole area just kind of scars in and forms this thick, kind of very protective scar tissue. And again, this was our only option because in these large chest wall defects, there's not a single manufacturer of a titanium plate that ever recommends doing a bridging plate over a defect like this, because the hardware can break and then it can poke into something and then cause more problems as you deal with hardware fatigue over time. And so we had a very nice repair here. The patient got out of the hospital about 5 or 6 days later, and we'd seen him at least twice since the operation, and he was doing very, very well. I'll go back to my presentation here. Okay, so that was this case that we just saw. This was the Stratus underlay mesh, and then there was a finished product that we saw. So our surgical experience here with, and this actually really isn't just at Honor Health, because our group, covers multiple trauma centers now. But since May 2014, that's when we first incorporated rib fixation into our rib fracture pathway. We've done 427 cases to date. We've published 3 papers in peer-reviewed journals, presented at national meetings, and a number of our surgeons are teaching. But it's the same thing, right? Yeah. Sorry. And we've taught a number of courses, and even the new surgeons that we've hired, they're all being taught in rib fixation. We helped write the protocols for getting privileges for rib fixation at our hospitals, and we're teaching more and more surgeons. But one of the big keys in starting a program is you have to be persistent. There's going to be a lot of resistance. We had a big fight with our thoracic surgeons for a while because, they had appropriate concerns, but, I felt comfortable doing the procedure because I had done a number of them in my fellowship. I had spent, 4 months out of my 2-year fellowship working directly with the thoracic surgeons on their service, so I felt very comfortable operating in the chest. And, quite frankly, as a trauma surgeon, you have privileges to do thoracotomies. If someone is bleeding to death, you have privileges to open up their chest, clamp their aorta, cut out their lung if you have to, those are, not that this is an easy operation. There's a lot of things that you have to learn, some of it just from experience, some of it from talking to people, some of it from, knowing your anatomy. But, on the degree of difficulty and all of this stuff, it's not as difficult as some of the stuff that we have to do in the chest at times. And the Chest Wall Injury Society, I need to talk about that for a little bit. It was started in 2016 by Tom White and his colleagues, who's a good friend of mine in Salt Lake City. It became the Chest Wall. It actually started as the Chest Wall Injury Summit, and then became the Chest Wall Injury Society in 2017. Larry Lautenberg was the first president, followed by Fed Puraci in Denver, another good friend of mine, and then Adam Shuroff is the new president. And we just had our annual meeting in Santa Fe, New Mexico in March of this year. Next year's meeting will be in either March or early April. It's always at the end of March Madness. That's the way I always remember it. And it's going to be in Denver, Colorado. And the website is there at the bottom. I would encourage anyone who has any interest in chest wall injuries or rib fixation to join. Visit the website. One of the things that you get as a member is you get membership to the Slack, forum where you can literally, it can be 2 in the morning and you have a question about a case you're thinking about doing tomorrow, and just send out a text, send some pictures of the x-rays, and literally you'll have like tons of folks who fix tons of ribs tell you exactly what their thoughts are. So it's a very, very good and easy way to stay connected with, some of the leaders in operative rib fixation throughout the world. And, this is kind of the mission statement of the Chest Wall Injury Society. And it's not just about ribs. Obviously we talk about ribs so much, but they talk about various aspects of managing chest wall injury. And there's so much exciting stuff going on. They just completed their non-flail study. They just closed the study out I think last month. And they're analyzing the data now. This is going to be a huge landmark multi-center study looking specifically not just at flail and non-flail, but looking at only non-flail injuries, which will hopefully help answer some of the questions that folks have regarding the management of injuries that aren't technically classified as flail chest. So in conclusion, operative rib fixation has a clear role in the improvement of outcomes in patients with severe rib fractures. It's generally accepted for flail chest. However, patients with severe non-flail injuries can also benefit. And as always, we need more and more research, to help delineate which patients are going to benefit.